Good morning. My name is Zilli. I'm a radiation oncologist from Switzerland. I'm working now in the Oncology Institute of Southern Switzerland in Bellinzona, and I'm a specialist for GU cancers. I'm leading the GU tumor boards in IOSI. Yeah, I'd like to present the FLAME phase 3 randomized trials. It's the Dutch trial exploring for patients with high-risk prostate cancer the role of focal boosting to the dominant intraprostatic lesions. So patients were randomized to a standard of care treatment, so 77 gray in 35 fractions to the whole prostate gland, or the same schedule with a focal boost up to 95 gray to the focal boost to the dominant lesions. Results confirms that biochemical disease-free survival is improved of 7% by adding focal boosting. Disease-free survival is also improved, and finally the same for the same long-term toxicity, and no differences in terms of quality of life between the two arms. I don't think so. Certainly PSMA can improve our knowledge of the disease status. We can detect more patients with a CN1 disease, and we can adapt the treatment accordingly. At the moment, we don't have any evidence to reduce the duration of ADT in selected cases. I think that more than imaging in the future will be biomarkers that will guide the duration of ADT for these patients. So we had data coming from the STAMPEDE trial suggesting that for patients with very high-risk disease, it means CN1 patients with nodal positive disease, or patients with 2 or more high-risk factors, it means T3 or more, PSA 40 or more, and a Gleason score of 8 to 10. We can add to the 3 years of ADT, 2 years of abiraterone. These are the patients that can benefit at maximum from the combination intensification with treatment with combining ADT and androgen receptor pathway inhibitors. Yes, certainly we have evidence coming even from the STAMPEDE trial that the patient with CN1 disease with positive lymph nodes can benefit from this intensification. Certainly, considering the radiotherapy, we can implement external beam radiotherapy by using a whole periodic radiotherapy, boosting the nodes, or trying to escalate the dose to the dominant lesions, like in the FLAME trial. So I think it's certainly a very nice study suggesting that for patients with the Roche score for nodal invasion of more than 20 and negative PSMA imaging, we can implement the irradiation of the lymph node regions. At the same time, we have other ongoing trials, the RTOG, the pivotal booster trial in the UK, that will probably give more information in the future on the real role of whole periodic radiotherapy for high-risk prostate cancer patients.